Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan and my mission is to make psychology accessible to all. In today's video, we're going to talk all about the opiate epidemic. In this video, you're going to learn about the different classes of opiates and opioids. We're going to learn about the criteria that are needed to be met in order to get a diagnosis of an opiate use disorder. And then we're going to go to some of the significant consequences of opiates within society. So if you like this video, give a big thumbs up, subscribe, click the notifications tab, and here we go. Okay, so I think the first thing that we need to distinguish are the terms opiates and opioids. And I know that sometimes you'll see these used interchangeably, but they really do have distinctions. So when we use the term opiates, we're actually referring to natural compounds derived from the poppy plant, forgive the typo. So the poppy plant, you can have morphine as a function of it, you can have opium, you can have heroin. These are all the naturally derived forms of opiates. However, we also have synthetic and semi-synthetic medications that are made in the lab. So opioids is a more generic term which people use for natural or derived forms of these drugs that are made in the lab. And each of these drugs have different strength, speed of action, and tolerance level. So when we talk about synthetic and semi-synthetic opiates, we're talking about things like fentanyl, right? And we're talking about heroin, respectively, right? And these are synthesized in the lab in a way that we can mimic the properties of morphine. So the synthetic opiates that we talk about are fentanyl, methadone, pethidine, tramadol, and carfentanil, right? Each of these are much stronger than natural opiates, and it's designed to be that way. I am sure you've heard about the crisis with fentanyl, that even a few grains of fentanyl could potentially induce an overdose. By the end of this video, I'm going to show you some powerful research on what's going on with fentanyl and what's going on with opiates in general. So stay tuned for that. But synthetic and semi-synthetic opiates are much stronger. Now, when you think of prescription opiates, they're designed to treat acute pain involved in post-surgery or injury. They're also there for chronic pain or cancer treatment or palliative and end-of-life care. So the common prescription pain relievers we see are oxycodone or OxyContin is the trade name, hydrocodone or Vicodin, codeine, morphine, and others. These are prescription opiates. Now, this is going to be important when we talk about the criterion for an opioid use disorder, because these can be prescribed and they can be appropriately used for various forms of treatment. So opiates and opioids, you might hear them collectively referred to as narcotics, and narcotics can be ingested in many different ways, whether it be smoking them, inhaling them, injecting them using a needle, whether it be subcutaneously under the skin or skin popped, or you can mainline it, injecting it straight into the bloodstream. Right now, the injection method seems to be the most common method, although other strategies for ingesting narcotics have been increasing. Now, the intoxication that you experience is oftentimes described as a rush which is a warmth or ecstasy that comes upon a person. Sometimes describe it similar to an orgasm. If you've ever watched the movie Train Spotting, that gives a very good picture as to what that rush looks like. Now, this high can last for several hours. Uh, it's described as a high or a nod. Because these are central nervous system depressants, they're going to make you more lethargic and tired. So, hence the term nod. So, as I said, opiates create these effects through depressing the central nervous system. And it's similar to alcohol, benzodiazepine, barbiturates, and so forth in that regard that it, slows down the central nervous system. However, what we see is that the receptors are different. When we talked about alcohol, benzodiazepine, barbiturates, we were focused on the neurotransmitter of GABA. And what you're going to see is opiates bind to opiate receptors, right? And these receptors ordinarily receive endorphins, which are natural painkillers, and they produce the effects of reducing pain and tension, calming people down, but they also can induce things like nausea, pupil constriction, constipation, and so forth. So let's talk about the disorder itself. So in order to be diagnosed with an opiate use disorder, you need to track it for 12 months. That's the same criterion we've had for all of the other substance use disorders. And you need a minimum of 2 or more criteria in order to meet the diagnosis. So if you have either taking larger amounts of the drug over a longer period of time, failed attempts to cut down, spending a lot of time preoccupied with either obtaining the drugs or using the drugs or recovering from the drugs, or as they say, scoring the drugs, these kind of things are a criterion for the disorder. Craving is one of these things that may not go away even when you stop the drug. You may have that urge to use. But substance use disorders, opiates included, will interfere with your obligations at work, home, or in school. And you continue to use them even though you have interpersonal problems. You might retreat from important activities due to it. You might engage in risky behavior as a function of the opiates, and you continue despite some kind of problem that has worsened, or you continue to avoid, the withdrawal effects, right? So other features are tolerance and withdrawal. Tolerance, by definition, is the need to increase the amount of a drug to meet a previously acquired high, and withdrawal are the negative symptoms that happen when a person comes off the drugs. Now, I said a lot with these criteria, but I said you need a minimum of 2 in criteria A. That 2 to 3 would be a mild opiate use disorder. 4 to 5 would be a moderate opiate use disorder, and 6 plus would be a severe opiate use disorder, right? So we have the specifiers in terms of the number of symptoms in criteria A, but we also have the ability to diagnose an opiate use disorder even if it's in remission. That is to say, you previously met the criteria for opiate use disorder, but you're no longer using. So if you have remained clean and sober for 3 months, from 3 months to 12 months, that is partial remission or early remission. And then if you have 12 months plus, then we call that sustained remission, right? So if you've made it to a year without using opiates, we have a different specifier. We also can specify if the usage was no longer occurring due to being in a controlled environment, such as a rehabilitation center. So not only do we try and give a picture of what the person is struggling with, we try and give more information about where they are in the recovery process. So here's the thing about opiates. Opiates are very powerful. People become addicted very quickly. So after a few weeks of using, a person can be caught in a pattern of abuse and oftentimes dependence. And that tolerance grows quickly, quickly, quickly. And this becomes a problem because using things like heroin is very expensive. So you need to acquire more and more money in order to be able to support your habit. And what we see is that as this tolerance grows, a person might be more inclined to engage in risky behavior, such as stealing and reselling goods at a cheaper price. People might engage in drug sales themselves, or in some cases, people engage in sex acts or prostitution to score the drugs. So because this is a rapid acting condition, we have to keep an eye on it. Now, what are some of the withdrawal symptoms? Withdrawal symptoms include anxiety and restlessness. Most of the time, we describe the withdrawal as a rebound effect. So it's the opposite of what you would experience when you're intoxicated. So it shouldn't shock you that restlessness is part of that. We see things like twitching, body aches, again, rebound effects if it's a painkiller, vomiting, diarrhea, weight loss, dehydration, so forth. We said under the influence, you get constipation. It should not shock you that you get diarrhea when you're coming off the drug. So what are the dangers of heroin abuse? And by the way, heroin abuse is dangerous, but I'm going to move to the discussion along in the next couple slides about pill-based opioids, and then this new thing that has come on the scene called fentanyl. Okay, so what are the dangers? The most immediate danger that we have to think about is overdose, right? So we have in our offices oftentimes things called Narcan, just in case someone is in the process of a heroin overdose or an opiate overdose. Law enforcement carries Narcan. These are they reverse the effects of the drug, but you have to get that going very quickly. Otherwise, a person, their brain shuts down, the respiratory center become paralyzed, the breathing slows down, eventually they die. So we also understand that ignoring the issue of tolerance, I said it's a quickly developing condition, so a person can become addicted within weeks. We should not ignore the tolerance, because what we see is about 1 out of 50 people of those people who are dependent on heroin or other opiates die under the influence. That's powerful, right? Considering that there's a sizable community using opiates. Now, we also see that people are trying to make the drug stronger, so they're cutting the drug with toxic chemicals, things like gasoline and whatnot. And another significant danger as it relates to heroin is the potential of sharing needles, and bloodborne viruses emerge from that, things like HIV, AIDS, tuberculosis, and whatnot. So there are some significant dangers with heroin. But check this out. When we look at the problem of opiate overdose, really, we can see it in 3 waves. The first wave was in the 1990s when these prescription opiates flooded the market. And there were doctors who would prescribe 2 weeks worth of painkillers for a simple dental procedure. And that's a problem, because if a person is no longer in pain, what's the normal thing to do? They stop taking it. They might put it in their medicine cabinet forget about it and whatnot. And then they might have a family member come in, search their medicine cabinet, and then take those pain pills. Now, we do have pill give back centers. Most pharmacies have that. So if you're ever prescribed an opiate and you don't need it anymore, or opioid and you don't need it anymore, don't leave it in your medicine cabinet. That's inviting someone else to abuse it. Then we saw a very sharp rise in heroin, hence why I talked about it on the previous couple slides. But now we have to deal with the problem of synthetic opiate overdoses. And from 2013 to the present, there has been a very sharp increase in synthetic opiate deaths. So if we were to look at this graph, and this is the final graph, look at the opiate overdose rates across different drugs. So heroin has been around for a long time and it has its risk, but those prescription opiates, right, commonly prescribed, they're right about the same level. But when you get to these synthetic opiates like fentanyl and tramadol, these in particular are sometimes 50 to 200 times more potent than heroin. And it should not shock you that things like fentanyl account for roughly 75% of all opiate related deaths today. So we have a problem. We're trying to figure it out. We are seeing more and more fentanyl coming across our borders. So seizure rates of fentanyl are up, but usage rate is way up and overdose is even more up. So that is opiates in a very brief description. I hope you found it useful. I hope you know the difference between an opiate, which is naturally occurring, and an opioid, which can be natural or synthetic. I hope you've developed an understanding on how we diagnose an opioid use disorder, and then the grave dangers associated with usage and overdose. That's today's brief lesson. Once again, if you have anything, you have a reaction to it, put it in the comment section below. Like the video, subscribe, click the notifications tab. That will allow me to bring this video to a larger audience, and you will be helping me fulfill my mission of making psychology more accessible. Until next time, everybody, take care.